Well, welcome to today's video, and today we're going to be looking at vitamin D again because there's a couple of very convincing studies have come from Israel, large-scale community population-based studies, and again it's showing this consistent pattern. People with lower levels of vitamin D have higher levels of infection, higher levels of hospitalization, and we know from other studies they have higher levels of admission to intensive care. The evidence for this is just accumulating more and more all the time. And why national and international bodies have not organised a clinical trial on this, to me, now, is getting towards negligence. The evidence is so strong that we really need a properly organised clinical trial by the World Health Organization or the National Health Service or the Centres for Disease Control, wherever it happens to be. This really should be done now, and the fact that this is not being done, in my view, is getting negligent. Anyway, 4 studies. The first one is an Israeli study where they looked at low levels of vitamin D, and they found that that was associated with more cases and more hospitalizations. Second, even larger Israeli study, they looked at positive cases and then found they had low vitamin D levels again. So they did the same thing, just the other way around. They looked at the positive cases first, then when they looked at the positive cases, they had lower levels of vitamin D. We're going to look at some US guidelines, and we're going to look at a Lancet review paper. So that's the plan for today. So the bottom line is I am calling on international agencies to do a proper clinical trial on vitamin D. And this really, there's no excuse why this shouldn't be done. It really should be done. But the observational evidence we have now is so strong. The correlation evidence is so strong. Now, going into the detail, the first Israeli study. So the low plasma vitamin D, so that's the form of vitamin D in the plasma, the 25-OH vitamin D is the vitamin D in the plasma. So when that's low, the cases of COVID-19 are increased risk. And again, this is peer reviewed. This is a proper published study. So they talk about vitamin D as being a worldwide pandemic. And again, we've been talking about this for some time. We've looked at population studies before, and so many people are deficient in vitamin D around the world. Over 40% in the United States, for example, are vitamin D deficient, higher in certain groupings. This is a global problem, and we've known for some time this is associated with quite a few potential diseases. In fact, the associations are really quite strong for quite a few diseases now. So this study wanted to evaluate association of plasma vitamin D levels and the likelihood of coronavirus disease infection and hospitalisation. They started off with a very large group, but they've got it down to about 7,807 because that's the group for whom they had good vitamin D status information. Data was collected, as you might remember, February to April, and there was a lot of cases then, and the participants' blood levels of 25 OH vitamin D was known. So that's good. Now, what I like about this study is they do define their terms. Always nice to define terms, so we know exactly what we are talking about. Now, they are saying that suboptimal or low is below 30 nanograms per mil. So what they're saying is that sufficiency is more than 30 nanograms per milliliter, or if you want to measure that in terms of concentration as we do in the UK, that's 70 nanograms per milliliter is equal to 75 millimoles per litre. Those values are the same. It's just different ways of measuring it. Insufficiency was 20 to 30 and deficiency was less than 20. So low is anything here. This is below the level that we would want. So 30 and above is good levels. Anything below that is suboptimal or low. As we say, good sample size. Now, they did a lot of data on this group, and what they found out was that the risks for being male were increased, consistent with other studies. The risk for being older were increased, consistent with other studies. But what they found out, and this is starting to be consistent with some other studies now, is that obesity was not significantly associated with increased risk for COVID-19 infection or hospitalisation. So the earlier studies that show that obesity was a big risk factor, there's now a bit of a question mark over those studies, and this data likewise did not show that. So all the other comorbidities they looked at, and the other comorbidities were, as you would expect, but the obesity one was not, indicating that obesity may not be as big a risk factor as we had thought. Now, based on that population size, that nearly 8,000 people, what they found out was that over 7,000 tested negative, nearly 800 tested positive. So what that does really is it gives you a nice control group. So your control group there is 7,025 people in your control group. And then what you've essentially got there is an experimental group, 782. So you are comparing those with those. So that's your experimental group really, and that's your control group. So they tested negative, they tested positive for coronavirus disease. And of course they compared that with whether they were in this group here, insufficient or deficient, and or compared that with whether they were sufficient or not. So all pretty standard stuff. And what they found was the increased likelihood of COVID-19 infection of someone being diagnosed positive. The odds ratio was 1.45. In other words, people with low vitamin D levels were 45% more likely to be diagnosed with COVID-19. But when it came to hospitalisation, people with low vitamin D levels were nearly twice as likely to be hospitalised. They were 95% more likely to be hospitalised if they had low vitamin D levels. So people with low vitamin D levels, 45% more likely to get diagnosed. People with low vitamin D levels, 95%, nearly double, more likely to be hospitalised. And this is on quite respectable sample sizes, comparing these two groups and then comparing that with their vitamin D status, whether they were in this group or whether they were in this group. So pretty standard. I mean, the group employed some quite sophisticated statistical techniques, but it's all fairly standard stuff. And they concluded that low plasma vitamin D levels appear to be an independent risk factor for COVID-19 infection and hospitalisation. In other words, it's an independent risk factor. So what they meant was here they had accounted for the other factors like the high blood pressure and the lung disease and the heart disease, but they still found that the low vitamin D levels was an independent risk factor, consistent with so many other studies. Now, this one, also an Israeli study. Now, this one's not yet peer-reviewed. I have read it, and it looks pretty good to me, I must say. It looks like quite a good study, so I'm more than happy to report it. But it has not yet been peer-reviewed. I expect it will be in the next week or two. And this is a large-scale study all over Israel. They found 52,000 people were infected, and about over 500,000 they were able to use as control. So again, we've got two ready-made groups here. That many infected, that many not infected. So it gives us really good numbers to compare on and contrast the vitamin D status between these two groups. Hardly need to read the results out, do I really? These were their conclusions. Greater incidence of COVID-19 with lower vitamin D levels. It's getting a bit boring, isn't it? Greater incidence of COVID-19 with lower vitamin D levels. But it's not boring. This is people's lives we're talking about. But the same results are repeated over and over again, study after study. Higher infection prevalence with lowest vitamin D levels. So the lower the vitamin D levels were, the more likely someone was to be diagnosed. As if we couldn't have anticipated that. Significant protective effect in those who had supplement over the previous 4 weeks. Wow. We are talking a big scale survey here. And they are saying that people who had been low of vitamin D before, but had increased it over 4 weeks, after just 4 weeks of vitamin D supplement, there was a big protective effect against COVID-19. That is a remarkably significant statement. And when researchers like this say significant, what they mean is it is statistically significant. They are more than 95% sure, and in quite a lot more than 95% sure, in fact, that this is a valid result, a significant protective effect in those who had supplemented vitamin D over the previous 4 weeks. Big study, that's what the numbers are saying. Is this proof? No. This is a large-scale correlation observational study. How would we prove it? We need a randomised, blind, controlled clinical trial. Why is this not being done? This evidence is so powerful now. I mean, if it, you know, as a layperson, I might almost say case proved on this. But scientifically, we can't say that because we don't have the clinical trial data. But boy, is the evidence accumulating. Now, joint guidance on vitamin D now this is various American groups. Joint guidance on vitamin D in the era of COVID. Now, this one here is the American Society for Bone and Mineral Research. This one here, I've written these down by the way. This one here is the American Association of Clinical Endocrinologists, Endocrine Society. This one is the European Calcified Tissue Society. In other words, they specialise in bones. This one is the National Osteoporosis Foundation in the United States. And this one is the International Organisation of Osteoporosis. So these sort of bone neuromuscular type people, of course, have been studying vitamin D for a long time. But they've carried on, so no, that's fair enough. Now, what are they saying? Spend at least 15 to 30 minutes with direct sun exposure each day, avoiding sunburn. Of course, it depends on the sun, doesn't it? Most older and younger adults can safely have an intake of 40 to 1,000 international units as a supplement if they're not getting enough sun. Now, if you watched that video a while ago that we did with Matt, the doctor from Australia, he said that to make enough vitamin D, the sun needs to be 45 degrees in the sky, and it depends on the body surface area that's exposed to the sun. But he said if you go out in the sun and you've got your shorts on in your back garden, you get a bit of sun front and back. If you stay in the sun for half of the time it would take you to get sunburnt, you'll make 20,000 international units of vitamin D. That's a lot. That's a lot. So my 25 microgram tablets there, that's equivalent to 1,000. So going out in the sun would be like taking 20 of those tablets. So it's quite a lot. Now, it also depends on the body surface area. So this is my pathophysiology book I wrote a few years ago. And there was something in there called the rule of 9. And this is the rule of 9 that's used for working out the body surface area that's burnt in people that are burnt. And what it is the head is 9% of the body surface area. An arm is 9% front and back. The trunk is 18% for the front and 18% for the back. And the legs are 18% each of body surface area. So this is called the rule of 9. So it's like 9 for an arm, 9 for an arm, 18 for a leg, 18 for a leg, 18 for a front, 18 for a back, 9 for a head. So you can see why it's called the rule of 9. You couldn't see me then, but never mind. I'll do it again. 9, 18, 9, 9, legs 18, 18, back including the buttocks 18%. So you can see how much vitamin D you're going to make depends on the proportion of the skin that is exposed to the sun. So if you can get a bit of sun, half the time to getting sunburnt, you're going to make 20,000 units of 20,000 international units of vitamin D, which is a lot. Heck of a lot. But of course, many of us aren't in the sun. That's why this group is recommending people that aren't in the sun can take this supplement. But I note they are recommending the low supplement. Now, to be fair, if you're taking this every day for years, that is going to build your level up and it's going to maintain your level if you take it every day for years. But of course, many of us are short of vitamin D. We need to bunk it up a bit. So they're being very conservative in their dosing there. Now, this is the review article from the Lancet now. Vitamin D and COVID-19. Do deficient risk do the people that are deficient risk a poorer outcome? And again, it's a recent article from The Lancet, so we'll have a quick look through it. Comparing data across nations, mortality from COVID-19 is clearly higher in some countries than others. Okay, we accept that. Relative vitamin D status of the population needs to be measured, has been measured in many cases. Vitamin supplement should be especially important for older people, partly because their skin makes it more slowly, partly because they often get out into the fresh air less. Functions, well, we've known about the bony functions for ages, that's not new. The rickets in children that it can cause, but we now know about many other conditions as well, specifically talking about infections associated with increased susceptibility to infectious disease. So people that are low in vitamin D are more susceptible to infectious disease. So many research reports saying that now. Notably upper respiratory tract infections. Treating the lowest levels gives most percentage benefit. In other words, putting vitamin D levels up can help most people, but the people with the lowest vitamin D levels will get the most benefit quickly. In other words, it's kind of like a low-lying fruit, isn't it? It's the easiest to pick. So people with the lowest levels of vitamin D with supplements get their vitamin D levels up quickly. They'll enjoy a lot of benefit from upper respiratory tract infections quickly. Moving on to COVID-19 specifically, now the virus emerged and started to spread in the Northern Hemisphere at the end of 19. It was winter time, low vitamin D levels. The levels in the blood are lowest. We know that's true from numerous epidemiological studies. Vitamin D levels go up in summer, down in winter on a population level. Very often when they go up in summer, they don't go high enough, but they go up, but in winter, they go down. This is known from multiple countries, multiple studies. COVID-19 mortality was significantly associated with vitamin D status in different populations. So again, looking at different populations, people with COVID-19 were more likely to be shortage of vitamin D. People with more serious COVID-19 were more likely to have the more serious the COVID-19, the more likely it was that their level was low. And we know from other studies, the Indonesian study, for example, that people with low levels of vitamin D were more prone to intensive care. And as we learned from that other trial data that we looked at just a few days ago. So the evidence for this is really from all over the world now. It really is strong and accumulating. Nordic countries who have done quite well. So Sweden, Norway, Denmark, Finland. I don't think Finns like being called Nordic, but they're those northern countries. But what's true is Finland, Norway, Sweden and Denmark, because they're so far north, they've known for quite a long time now, for about 10 years, that they're much more likely to be short of vitamin D than people who live further south. So a lot of their foods are already supplemented with vitamin D. A lot of the people know about it and a lot of the people take vitamin D. So in the Nordic countries where severe disease and deaths were less common, the vitamin D status is higher. It is all completely consistent evidence. Italy and Spain prevalence of vitamin D is surprisingly common. So ironically, the Nordic countries that don't get the sun, they know about this and they take extra vitamin D as food supplements. Italy and Spain, which are sunny, that they don't supplement their food, but they also tend to keep out the sun. So ironically, these people that live in sunny countries have surprisingly low levels. The levels of deficiency are surprisingly common. We know that the darker the coloured skin, the more slowly it produces vitamin D. In the UK, more than 4 times more likely to die from COVID-19, people with low levels. Well, the ethnic minorities are more likely to die. And in the States, that was about 4.7%. And that was, from memory from the States, it was about 4.7 times increased risk in African Americans and American Indians, First Nation Americans. And from memory, I think the risk was about 4.6 times in Hispanics. So these are huge differences, huge levels of increased levels of risk, because darker coloured skin is making vitamin D more slowly. Now in COVID, this is still the Lancet article, Vitamin D supports production of antimicrobial peptides. So these are proteins in the mucous membranes, in the respiratory tract, that help us to fight off viruses. Vitamin D also helps to reduce the inflammatory response. Vitamin D is known to increase the enzyme angiotensin converting enzyme 2. Now I'm not going to do that in detail, but so it produces more of this. More vitamin D causes production of this enzyme. But SARS coronavirus 2 downregulates expression of ACE2 receptors. Now this is a bit confusing. What actually is happening here is if you give vitamin D, you produce more of this enzyme, the angiotensin converting enzyme. And if you have more of the enzyme, the receptors, the ACE2 receptors on the surface of the cell downregulate, and you actually get less of these receptors. So more angiotensin converting enzyme in the plasma means that you need less of these ACE2 receptors. And of course it's the ACE2 receptors that are the absorption site for the infectious spike on the virus. So if you have more angiotensin converting enzyme, you can downregulate your receptors, and that means there's less places for the virus to get in. That's just theory. Well, it's more than theory, but we don't know whether that's the case in COVID-19 or not. But it all fits. It all makes sense. It could well be completely true, because vitamin D is promoting expression of the angiotensin converting enzyme, and the more of that, the more you're going to downregulate the ACE2 receptors. But basically we know that vitamin D is involved in many aspects of the immune system. As far as I understand it, all of the immune cells, the lymphocytes, the monocytes, the neutrophils, all of the immune cells have vitamin D receptors. Vitamin D is an immunomodulator. It stops the acute respiratory distress syndrome. At least that theory all fits and makes sense. It all fits together, vitamin D being an immune modulator. Again, I can't say that definitely. I can't say vitamin D prevents acute respiratory distress syndrome because the trials have not been done. Although there is trial data that we did look at that's starting to suggest that, but we need large-scale trials, and they really need to be done. Now, Irish Republic have been very on the ball on this, very on the ball in the Irish Republic. This lady, Roseanne Kenny, I think she was the lead investigator in the national study, Trinity College Dublin. Yeah, lead investigator. She says this. These are all direct quotes. The circumstantial evidence is very strong. So this lady, leading doctor academic, spent a lot of time studying this, leading the whole Irish Republic study. Circumstantial evidence is very strong. We don't have randomised controlled trial evidence, but how long do you want to wait in the context of such a crisis? Boy, do I agree with that statement. We don't have the trial data, but we need it. But hey, how long are we going to wait for? We know vitamin D is important for musculoskeletal function, so people should be taking it anyway. Vitamin D supplements should normally be given to care home residents unless there is an extremely good reason not to do so. Because they're elderly, even if they're in the sun, they produce it more slowly. They tend to be indoors, and of course, who's died mostly from COVID-19? People in longer-term care facilities. Adrian, can't say his name. Adrian from another academic from Queen Mary University of London, again leading academic. At best, vitamin D deficiency will be one of many factors involved in determining outcome of COVID-19. Of course, this is one factor. But it's a problem that could be corrected safely and cheaply. It's a variable we could get rid of. And simple changes in government guidelines could do this within a few weeks. You know, instead of talking about moonshots for testing 10 million people a day, you know, if the Prime Minister, the Chief Scientific Advisor and the Chief Medical Officer advise people to take vitamin D supplement as winter approaches, then people would do that. They would do that. But at the moment, that advice is not being given, or the advice is being given and it's not talked about much, and it's vitamin D at low levels. And Adrian finally saying here that there is no significant downside to speak of, and good reason to think there might be a benefit in giving vitamin D. Now, this is the vitamin D I'm taking at the moment. This one happens to be, the last one was Asda, this one's Holland About. It's all the same stuff, same chemical. Vitamin D3, which raises your blood levels slightly more than vitamin D2 does. So most of this is vitamin D3, but vitamin D2 would do as well. And this is 25 micrograms. Now it gets a bit confusing because 25 micrograms is 1,000 international units. So 400 micrograms is 400 international. See how easy it is to get confused. 400 international units is 10 micrograms. 800 international units, 20 micrograms. 1,000, 25 micrograms. 2,000, 50 micrograms, and 4,000 international units is 100 micrograms. So early part of the year, me personally, I was taking 2 of these a day. That's 50 micrograms, which is 2,000 international units. Over summer, because I try and get out in the garden and the allotment, I've been taking less. But as winter approaches, I'm not getting the sun again. Personally, I'm going to start taking 2 of these a day. And as well as the COVID situation, there's some very good evidence that I will look at another time about vitamin D being good for prostate health, which all men of my age are concerned about, or will be pretty soon. Right, that's us for today. I just renew this plea, really. We need these clinical trials, and if these aren't done, I think governments and governing organisations are being negligent. The evidence we've given in half a dozen videos now, again substantiated by large-scale epidemiological studies from Israel, really, in my view, very, very difficult to argue against. So thank you for watching, as always.